Is the region between the chest wall and your arm. This whole region, this is called the axilla or the armpit. So it has the anterior axillary fold and it has the posterior axillary fold, as you can see in the diagram. So it is a pyramidal structure. If we can visualize, this is a pyramidal structure. It has multiple boundaries. It has the anterior surface, the posterior surface, the medial surface in purple, the anterior surface in red outline. This is the lateral aspect of the axilla, and this is the apex, and this is the base. Since we have talked about the anterior chest wall and the back muscle, it will be really easy to learn about the all these boundaries. So let's talk about the anterior wall and the apex. This image is taken just if we look at our body from a superior aspect. If I had my eyes just on top of me, if I was looking downwards, so I'll be able to visualize this. So this is the apex of the axilla. So it is formed by three boundaries. The medial aspect is formed by the first rib. The posterior aspect is formed by the scapula, and the anterior aspect is formed by clavicle. Then we can come on the anteriormost surface of the axilla. So the anterior wall of the axilla is formed by what was the anteriormost muscle which we talked about, the very first muscle in our lecture? That was the pectoralis major. The pectoralis major forms the anterior wall of the axilla. As we come downwards, we have pectoralis minor, which also forms the anterior wall. So all the anterior chest wall muscles form the anterior boundary of the axilla. That is why we went over all the anterior chest wall muscle. Now it's really easy to know about the boundary of the axilla. So all the anterior chest wall muscles form the anterior boundary of the axilla. That includes the pectoralis major, which we just talked about, the pectoralis minor and the subclavius muscle. So subclavius, pectoralis minor, and the pectoralis major over here. This is another image. This image is basically taken from sideways, as if you're looking at me from side. So we can appreciate the anterior wall and we can appreciate the posterior wall. So the anterior wall is formed by, this is the pectoralis major, this is the subclavius muscle, and this is the pectoralis minor muscle. This is the anterior wall of the axilla. All of these muscles, which is the subclavius muscle and the pectoralis minor, these are basically attached by a fascia called clavipectoral fascia, and it extends all the way downwards, and it attaches on the lowermost aspect of the axilla, and basically pulls the axillary skin upwards, forming the anterior axillary fold. This is the suspensory ligament. So medial wall is really easy. What was that muscle which was fanning outwards in this direction, going all the way backwards towards the scapula? This was the serratus anterior. So this forms the medial most wall of the axilla. So the lateral wall, so what students really have a problem, so they usually understand the anterior wall, posterior wall, all of those walls, but they have a hard time visualizing the lateral wall. So we have done the anterior wall, the medial wall. The lateral form is actually formed by the humerus. It's actually formed by the humerus, and specifically the intertubercular groove of the humerus. So if you can see, this is the humerus, and this is the greater tubercle, lesser tubercle, and this is the intertubercular groove. This thin lip, this thin line is forming the lateral aspect of the axilla. I hope it makes sense. So we have done the anterior wall, the medial wall, the lateral wall. Now it's time to talk about, and the apex. Now it's time to talk about the posterior wall and base. So the posterior wall is formed by the muscle which were present posteriorly. So just think, what were the muscles that we talked about that were present posteriorly? So we had so the muscles. So we had latissimus dorsi, and another muscle which we didn't talk about that forms the posterior wall of the axilla, that is the teres major. So we are looking. So if this is our skeleton, and we remove the rib cage, if we remove the rib cage, the thing which the angle that we'll be looking at is the image projecting on your screen. This is the anterior side of the scapula. This is the anterior side of the scapula. So the posterior wall is basically formed by the teres major and the latissimus dorsi muscle. Along with, there is a muscle which comes from here. This is the subscapular fossa. This muscle is called the subscapularis muscle, and we'll see it also forms the posterior wall of the axilla. You can see we did the anterior wall. Again, this image is from the lateral view. So we have done the anterior wall. Now we have to discuss about the posterior wall of the axilla. So we have the subscapularis muscle, the teres major, and this is the latissimus dorsi. So let's, and just a quick point, that is when we just 1 second. Okay, so when we talk about the muscles along the shoulder joint, it's really important to note that there are some spaces or grooves which allow the passageway for different neurovascular structures. So you can see that we have teres minor over here and the teres major, along with the humerus and the long head of triceps. When they cross, all of these structures cross, they form a quadrangular space, which is actually a space for the passageway of the axillary nerve along with posterior humeral circumflex artery. So we have talked about the axilla. Let's talk about what the axilla actually contains. And it's really easy to understand since the muscles and all the structures of our arm need blood vessels. So all of these blood vessels are actually coming from the neck and going down from the axilla into our upper limb. So the first content that we'll talk about is the axillary artery, then the axillary vein, along with axillary lymph nodes, fat, and perhaps the most important thing, that is brachial plexus. That will have a class video on its own. Okay, so let's talk about the artery. So the axillary artery, which you can see over here, is actually a continuation of subclavian. So it's one artery, and according to its location or different areas along our axilla, we name it differently. So initially we have the subclavian artery. Once it crosses the first rib, it becomes the axillary artery, and we have three parts for axillary artery: the first and second and third. It's named according to its location to the pectoralis minor muscle. The part of the artery which is superior to pectoralis minor is the first part. The part of the artery which is just posterior is the second part, and the part of the artery which is posterior to the axillary artery, the part of the axillary artery which is just below the pectoralis minor muscle, is the third part of the axillary artery. So above the pectoralis minor, first part; behind the pectoralis minor, the second part; and just below is the third part. As the axillary artery goes downwards, at the lower border of the teres major muscle, this axillary artery is converted, or it changes its name to the brachial artery. Okay, then we can talk about the venous supply too. So it's really important to know that usually the venous supply is followed by the venous supply follows the arterial supply, but in our arm, so most of the medial venous supply, most of the medial venous supply is being drained by the basilic vein. It is drained by the basilic vein, and the most of the lateral aspect of our arm is being drained by the cephalic vein. And you can see this is the basilic vein, not the this is the basilic vein, not the brachial vein. This is the basilic vein, and this is the cephalic vein, which drains the lateral aspect. And the basilic vein, when it goes upward, it forms the axillary vein, and it will form the subclavian vein, like we mentioned in the arterial supply. Again, the lower border, at the border of the teres major, it forms the axillary vein, and at the border of the first rib, it forms the subclavian vein. And you can see the cephalic vein drains the lateral aspect of the arm into the axillary vein. This is another image. We have the arterial supply, the venous supply, along with the lymph nodes. And let's talk about the lymph nodes itself. Usually when we talk about lymph nodes, they are not that high yield for any organ, not that important. Only when they're important is when we are talking about tumors. But for axilla and the pectoral, the lecture on axilla and the pectoral region, you have to know about the lymph nodes. And these are very easy to characterize and name. So we follow the nomenclature along. The nomenclature is the same as the walls of the axilla. So we had the anterior wall, the posterior wall, the medial and the lateral wall, as well as the base and the apex. So the cluster of lymph nodes which are present on the anterior wall is called the anterior nodes or the pectoral nodes, because the pectoral muscles present over there. The group of lymph nodes present on the lateral wall is called the humeral lateral node, because the humerus forms the lateral wall. The group of lymph node which form the medial, which are present on the medial aspect, are called the basically we have medial node, which we haven't specified over here. We have another group of lymph node in the posterior aspect. This is called the subscapular node, and it's because the subscapular muscle is the posterior most muscle. These all drain into the central node, which ultimately drain to apical, and all of this will be draining via the thoracic duct into the venous supply. Thing to note over here is that, and the clinical correlate is that if there's any problem anywhere along the arm, so the lymph nodes are being drained into the epitrochleal lymph node, and from there they drain into the axilla. So if you have an infection or any tumor or anything that is sinister that is happening along the upper limb, it will actually drain into the axillary nodes, and you will actually find the swelling or tenderness over there, specifically in the lateral nodes. Also, most of the anterior chest wall along with the posterior chest wall is being drained into the axilla. So if there's any problem in both the structure, the anterior chest wall or the posterior chest wall, you will have swelling of the axillary lymph nodes. Either swelling, there will be swelling, whether it's tender or not, you'll be able to, it will clue you whether it's an infection or a tumor. The mammary gland, which is the breast, all of its lymph node drainage is being happening into the axillary lymph node, and specifically the pectoral lymph node, which is the anterior most group. This is where the lymph nodes are being drained. And for a consultant, if they have any, for example, you have a patient that comes to you in your clinic, and he or she comes, basically she comes to you in your clinic, and you are suspecting breast malignancy, and you ask the patient to get a mammogram done. They get a mammogram done, and you see a lot of microcalcification. You're suspecting, you have to see whether the cancer, you're suspecting cancer, and you have to see whether the cancer have metastasized or not. Remember the TNM staging of cancer, neoplasia. So T is for tumor, N is for nodes, and M is for metastasis. So you have to see whether there is any nodal involvement. So you don't really go in and remove all the lymph nodes. What you do is you remove the specific lymph node. You take the biopsy from the specific lymph node, which is at the closest proximity to the breast gland of that site. And you take a biopsy, fine-needle aspiration, and you check if it has cancers or not, if it has cancer cells or not. If it doesn't have cancer cell, it means that the cancer is localized to the breast itself. That group of lymph node where the cancer in any part of body that commonly spreads toward the first group of lymph node where you take the biopsy from to screen for cancer, that group of lymph node is called sentinel lymph nodes. And you will come across this question most likely in your clinical rotation, where your surgeon will be asking you this, and hopefully by then you'll be knowing the answer. And that is the significance of the lymph nodes when it comes to the axilla. And with that, we are done. I hope you found this useful. I'll see you guys in the next lecture. Until then, just take a lot of care, and bye-bye.